Okay, so this paper is about maternal mental health and how do they expect that kid to be in the future, and whether when those kids are vaccinated or versus not vaccinated. So it's basically expectations about the future. You put yourself in the future self and visualize your child's health or education expectations and earnings and so on. So we did this project in Ahmedabad and Sawabi district of KP. And we started piloting for this project 5 years ago. We did pilots in Peshawar and Attak suburbs and Rawalpindi suburbs. And yeah, so we just got our final results, and this is the first time I'm presenting this work here. We are presenting this work, this first time at LUMS. So, and by the way, I feel very lucky to have been working with Basit. He's a gem of the person. I think he's one of the finest economists this country has produced. No doubt about that, and even finer human being. So I have learned a lot from him over the years. And personally, if I think if I could bet on two people who could possibly win Nobel Prize for Pakistan, I think one would be Basit, other would be Atif Mia. So let's hope, inshallah. Fingers crossed. No, I'm serious, really. I'm not. I mean, I told Basit, even said, "Chhod yaar, ke yaar, pate mein ye kaam karne de," something like that. So, but his work is very unique. Okay. So now I'll tell you a story. Once we were doing a pilot. Basit was here in Pakistan. I arranged our survey firms. We engaged two survey firms, and I arranged them. Okay, so let's go to do the pilots with them 4 years ago. 3 years ago, I guess. December 2020, I guess. So Basit and I and those enumerators, we went to Peshawar, suburb areas, and they arranged a room or all that. So we started, the piloting fathers mainly, because it's a very conservative society, especially rural area of Peshawar, KP, suburbs, or all that. So Basit said to the enumerators, one of the enumerators, "Man, can we talk to this child's mother? And because we want to take their viewpoints too, right? I mean, so that enumerator said something in Pashto to that child. He went home and came back and said something very angrily to that guy. So we asked him what? So he said, उसने कहा है कि मेरी माँ कहती है मुझे क्यों बुलाया है? तो मैंने बस कहा यार ना कर यार, मदर को ना ही बुला उसकी. ये मतलब कि ये सोसाइटी इधर लाइक इधर शायद क्लाशनकोफ निकल आएंगी, तो लेट्स गो होम. I'm just saying. So we had lots of fun doing all the field work too. So anyways, so let's get started now. Okay, so let me now stand up a bit. So as I said, so we all know that immunization is a very cost-effective way of ensuring public health. It doesn't really work only at present, but actually throughout your lifespan. But there is alarming rate of immunization rate in Pakistan, especially in KP, where the children only complete immunization at the rate of 49%, and we are talking about average of KP. So in rural areas and across socioeconomic households, this rate is even lower, right? So this is really a big public health issue, and obviously the polio is also very endemic in Pakistan, and there are only two countries in the world where polio still exists, Afghanistan and Pakistan. And mostly in KP region of our country, because of course there is cross-border transmission of polio, which you cannot stop easily. And polio has been resurging since 2018, and then not only polio, but around the time measles and other diseases, especially, were rising in 2015-16, while they were going down in Sri Lanka and India. So there are some myths and perceptions surrounding immunization in Pakistan, which is that, and most studies have only looked at the supply side factors, which is the government mismanagement, corruption in the UNICEF fund that government gets, and then obviously, especially in case of polio, every deputy commissioner of a district is bound to be very, very quick respondent if something happens, right? But there is really a drawback to that, which is that once you really force people to do something, they become doubtful about it. What is this? I mean, you never ask us about anything else, but for polio, you come to our doorstep every month and put drops in our children's mouth, and it's like it's over. How many drops do we need? You come every month. I mean, that is creating some fears and suspicions, uncertainty, and all that. And look, working on this topic for last many years with Basit and Adeline, I realized there's a huge problem. It's not like you blame people, but you really blame first our government, that they do not create the demand awareness. What they do is give polio every month, and they have hired 700,000 plus workers for this cause. And still polio is not going anywhere. So one could wonder what is really going on. Maybe they get tons of money from donors, and obviously they don't want that money to stop. Who wants money to stop in Pakistan coming from outside? So I mean, that kind of suspicion. So there is myths are there that polio, I mean, these drops can overdose, and it's religiously bad, it's Western conspiracy, or it can make children sterile, and the foreign countries do want Pakistan's populations to go down. That's why they have really focus on polio and things like that. And that has, we believe, has affected their motivation for other vaccinations too. Okay. So one innovation, obviously, to compare to the past study, is that we focus on the demand side, not the supply side. So, and mainly also, I think our novelty is this, that we feel that in our country, hardly anyone takes stress and depression seriously. And this postnatal and perinatal stresses are very, very, very common, even in the cities, the mothers and educated mothers, and we are talking about the mothers who really live in stress all the time. Maybe they are happy. Somebody said, oh, in my village people are much happier. Well, let's go back to the village then. Why are you here? Really, I mean, thing is that they have settled down on a very low level equilibrium, and they think that's life. So this is what we are doing. But then we also, and there are many papers that have actually kind of provided information and looked at the effect of information on vaccination, as well as sending kids to schools and this and that. So, but and there are many. I will not really go into the literature. But we are doing is that we are actually conducting RCT in KP, and our intervention is this, that our first hypothesis is the PFA, which is called psychotherapy first aid. We provide for the last year or more to the mother of newborn child who is 1 month old only, and we recruit them. And then over time, we actually give them counseling through the counselors, doctors, so that they really get relieved of the burdens of the day-to-day issues they are grappled with, and it's just to promote their health and mental health. And then second is that we also, in PFA, we also add, second treatment is some influencer effect. What is that? I will show you. So we do baseline, we do end lines, sorry, midline, end lines, and we recruit this since I don't have time. So, so first we recruit physically through the lady health workers and the visitation of the mothers to the health clinics, nearby health clinic, and then we provide basic support in the call one, trained counselor, build trust with mothers and all that. So it's a call two, which is PFA plus influencer effect, and which is influencer, those are the role models like government officials with the EPI, they will tell through the message, audio messages, what really is this about, why it is important. Doctors will tell what really vaccines do biologically to your body, and then religious figures will promote Islamic lessons to why we should take care of families and kids. And then there is a network effect. In your neighbor, there's a pro-vaccinator mother who would really further the idea of giving vaccination. So, and so on, and there are many others. And then there's call 3, which goes to, again, visualization, which is imagine yourself in the future, which is that what happens if your kids gets vaccinated versus does not get vaccinated. What is the probability that he will fall sick? What is the probability he will finish school? What is the probability that he will earn this much? What is the probability he will get married? Or what is the probability that he will be treated fairly in the society? And so on. There are many others. So this is about just not the information, but visualization. Visualize yourself, right? And if polio happens, what will happen to the child? And how will you deal? So basically, just to force them to think and plan accordingly. And there are many. So and we also keep them engaged with the messages or all that. So these are baseline, and then we didn't give cash, but the gifts in the shape of some gift calendars, but also mobile minute transfers. And control group and so on. So I will not really go into details. This is baseline characteristics, which suggests that panels are balanced. And then this is our model. I'll not go into this. These two treatment groups. Not go into this. Again, baseline, balance at baseline, but treated status. Again, that is, we are using this Imbens and Robbins' new model because the t-test has been stated to be very, very conservative and regressive too at the same time. So we are using the newer test. If the balance is less than 0.25, then the control and treat group are comparable. So that's what it is. So, and then balance at baseline by treated status, and then attrition rate. So you can see the attrition rate is huge. Why? Because we are doing this for a year, right? Engaging them for a year. I mean, some of the kids died, and most resistance was from husbands. Who are you talking with for this whole year and this and that, these people, something like that, right? So they resisted. So that's why we had huge, okay. So let's come to the result. So what this says, that PFA, which means the psychological treatment, worked. You see? Which means, so on average, vaccination at the end line a child gets is 4.42 vaccinations. And our treatment increased that by 0.3 vaccination, which is a third of a vaccine. Now, this might look small to you, but if you really scale up and think about the whole population in KP, if really gets 0.3 vaccination more, so you can see that how many lives you can really affect, and this is just the part of PFA. And then you can see it works for polio, right? But we started with polio, but polio is not a choice variable. You are forced to take polio vaccination. They come to your doorstep. For these one, you go to the health center. And then hepatitis B, we do not see the effect. For pneumonia vaccine, we see the effect. 74% complete pneumonia vaccine, but our treatment increases that by 5.4 percentage points. And then pentavalent larger effect by about 9 percentage point, our treatment, PFA, increased, while PFA plus influenza doesn't. It has negative effect even. So which means in the net term, it will cancel out. The effect is same. And rotavirus is also again the large effect for the PFA, 6.4 percentage points it increases, while it is only what? Completion rate is what? 50%, right? So, and then we looked at, okay, PFA effects on PHQ-9, which is your mental health. There are many questions that we took from the authors at Harvard Medical School in consultation. So, but what we see that PFA, psychological treatment, doesn't really affect somebody's mental health as such, right? Because this is perhaps too light a touch. I mean, if you really get into some depression, serious depression, you have to visit psychologists for 9-10 times. There are sessions after session, and we are just doing what? Engaging for 3 calls and counseling and this and that. But this is amazing, which is just 1 minute I will take, if you allow me. So this is amazing. Why? Because this one is that PFA works for increasing their knowledge score. I mean, we did not give them any knowledge about immunization, but we only asked that, look, how much do you know about the immunization? Time of that, effect of that, and that positively affect with the 7.2 percentage points, which means that women perhaps know. And they are more sensitive about their kids than fathers. It's just that when you counsel them psychologically, they recall better. And then they act, go to the center. Otherwise, okay. And the PFA, we see that all vaccination minus no vaccination, the probability that if you get vaccination versus no vaccination, how will that affect your child's expected disease, right? So we can see, you think if your child is vaccinated, the disease he will be less likely to get disease, right? So which is great. But we do not see the effect on what? Schooling. No schooling effect and no income effect. We're talking about rural population of KP. Very conservative society. They anyways do not think much about school, right? So they do not plan. So basically this will not really act in their mind to plan for their kids' education. And same goes for income. So, but the nice thing is that they do really have an effect on the short-term effects, which is that, okay, what if my child gets sick, what he will get sick in the future.
I think you have to come to the
end. And these are some iteration bonds. Okay, I can talk about that later, but so what we find here is that light touch phone interventions, light means here that light psychological counseling really works. And visualization and planning can promote early childhood immunization. Additive influencer effect, which is role model effect, we do not see that effect, which tells us that, look, people are aware of it. We don't really need to tell them that vaccination is good or bad. It's just like that when they come out of the day-to-day issues and all these pressures of their daily lives, they act. And then potential mechanism is knowledge acquisition, behavioral constraints, and no effect on mental health, and so on and so forth. Okay, we stop here.
Okay. Great, thanks a lot. And then we have Takashi coming up with the discussion.
Yes, I'm Takashi Kurosaki. Can I borrow the Takashi Kurosaki from Hitotsubashi University, Tokyo, Japan. And I have prepared, my comments on the slides. Yeah.
I thought Maryiam was my discussion, so I sent her my slides. You have paper, but paper we haven't included results yet, full results, but slides.
Yes, exactly. So what I read is the previous version without final results. So my comments are on the paper without final results, and he showed the
the
final results today. So basically, what this study did and its contribution is that one of the reasons for Pakistan's low immunization rates is stress and information friction of mothers. So in this study, they conducted an RCT in Abbottabad and Swabi in KP to remove these constraints. And interesting thing is that psychological support with visualization techniques is the major treatment. And also similar support and information provision through influencers is another treatment. And my evaluation is a very unique attempt with a focus on maternal stress. And another innovative aspect is that they use the IVR, interactive voice response, which is based on phone-based intervention, which is actually I am presenting my project next, and this is also based on this technology. And many other papers are coming on using this one. And using this technology is a very important considering the research constraint during the COVID-19. So I'm this is a very valuable research and looking forward to know the final results, and the final results are already shown here. And I really like there is a positive effects on immunization and the effects on stress and expectations, and to some extent puzzling, and he already gave some interpretation. So, but let me give some time to digest this. So I will just leave my comments on the final results. So regarding the methodology, I have 5 comments. So first comment is that this is an individual level randomization recruiting participants through lady health workers or health facilities. So isn't it possible to completely avoid interactions among participants under different treatment? And if not, then we expect some spillover effects. So especially regarding the influenza intervention, some spillover, I was afraid. So how do you control these kind of things when you interpret the results? First comment. Second comment is that especially regarding the information treatment, the heterogeneous impact is expected due to the difference in anti-immunization misunderstanding. And this can be directly measured by the strength of the extreme groups, but it is difficult. And is it possible to conduct this heterogeneity analysis, or can it be possible to interpret the result of a heterogeneity analysis through this angle? That is my second question, because we know that in some parts of KP, very strong anti-immunization beliefs, but in others, maybe that feeling is weak. Third comment is that it's a phone-based intervention, and this intervention may suffer from non or low response. And basically, they did an ITT analysis, and this can avoid this difficulty. But for policy implications, maybe we need average treatment effects. And in that case, is it possible to do kind of compliance-adjusted ATE? Because some mothers just listen to the phone without any attention, that kind of thing, just to get the reward. So that is my third comment. And the fourth one is, this is, he didn't explain, but some structural estimation and some parameter identification is not clear. And last one is that the main outcome variable of mental health is measured by PHQ-9 battery. This is based on subjective responses. So I'm just wondering whether some kind of response bias exists after the treatment. And in my another project, I'm doing objective measure of stress using amylase check in saliva spittle. So what kind of potential bias do you expect using this PHQ-9 battery to measure mental health? This is my comment. Thank you.
So thanks. We have just 3-4 minutes actually now left in this part of 4 minutes. So you want to respond directly or call in also some?
I can respond. Can you go back to my paper so that I can respond and show what we are doing in relation to the points? Where's the pointer? This is not my paper. That's not my. Yeah, okay, thank you. So the first thing you talked about spillovers, right? I mean, first of all, we're talking about rural population. Recruitment period ended, went on for several months. And obviously then we randomized based on that. And we tried to make sure that there should not be the neighborhood effect or spillover effects where we recruit mothers who live in just next door.
Oh.
So that's one. And second is that you're right about the phone intro. So this recruitment happened physically. But then we engaged them so that, because it's a long-term study, so we kept them engaged with SMS messages, week before the vaccinations and other, good gesture type call, and with the control group just to engage them so that they don't really fall into attrition so much. So yes, you're right, because of the husband's objections or all that, so many things. So that's why we got only, and at the end line we got only 54% of response at the end line. But that's why we are showing, even, which is actually not very common to show the balance between treated and the control group at the end line. So thankfully we have very good balance, if you could see by the test. And then this table, for example, this shows that attrition bonds, which is this is what saying that what really is the problem. So we may not observe everybody. This is based on our sample, just like employment data is based on the sample. It's not that the whole population we really interview and check about inflation, employment. So this is based on the sample. So what this says, what if everybody got vaccinated and we haven't absorbed them? So then the effect of the vaccination is even larger than our estimation. So which means that our results are underestimating the effect of treatment. And what if those we do not observe, none of them get vaccinated? And still we see the effect, positive effect, right? So both the cases we are trying to address. And then your effect was, okay, about the psychological, it's a phone-based intervention. I don't know if we could get their sample of their saliva right after our interview. And but then also it depends on, it's maybe too scientific, but it may not be very accurate too, right? I mean, at what time you take the saliva, right? So that's also, so I don't know. They might be very happy and saliva would be lying. Or I don't know. Right?
Yeah, ideally both, but.
Okay, thank you.
Okay, we unfortunately have very little time now for the open questions, but maybe one or two. Yes? Do you have a microphone?
Dr. Nomana, Professor of Psychology from Punjab University, and I think as a researcher of mental health and psychologist. In the first place, you have assumed that there is a correlation between the mental health of the mother and her willingness to have the vaccination, right? So you are seeing the decrease, improvement in the mental health through the that communication method that you were using, which you are calling psychological first aid, would increase the vaccination response from the mothers. So does your evidence show there's a correlation between willingness to have vaccination and the mental health of mother? And at the baseline, what was the percentage of mothers who you found with mental health problems? A. And B, the counselor who were doing the psychological first aid were locally, culturally, indigenously trained people or not. I question your assumption that the willingness to vaccine for children is related to only mental health. It's related to attitudes. Same as you saw in COVID vaccine. I personally am not a pro-vaccine person. It has nothing to do with my mental health. It has something to do with my scientific knowledge or information. So those kind of assumptions were there. It's just a comment. I know a study which has been done only teaches you better how to do things, maybe differently from the learnings. Thank you.
Okay. So Maybe I can answer this first, try to answer your question. One is, there are a number of papers at top journals, really, that have actually linked the mental health to the decisions that people take. When you are mentally upset, especially in prolonged period of time when you're depressed, you take wrong decisions. On average. I'm not talking about everybody. I've been very depressed many a time, but I take right decisions. But when I'm very happy, I take wrong decision too. I mean, that is possible too. But the point is that, yes, we know that people have misinformed beliefs based on myths and perceptions of their personality as well as perceptions that are affected by the society they live in. So you might have a good understanding of vaccines and they don't work or all that, but we're talking about the averages, how average people really think and see. And then, obviously, then mental health also affects your cognitive abilities. Like that bandwidth is very weak. And studies of science has proven that, I think. So then we tested. So we have first the pre-test. Based on the number of questions, as I said, which are approved and tested by the Harvard Medical School, we had Basit, he has that kind of approach, me not. So he had contacted those people, and then we collected all those evidences. And then first we collected their mental health at the baseline, then end line, and then the midline, and then the end line.
So
yeah.
I think we have to stop here, and to give some space also for Takashi. Next presentation. Thank you for the interesting presentation. And because I feel like the discussion here in the room gets squeezed a little bit, I really encourage you to get in touch with the presenters if you have suggestions or notes or questions.
Thank you very much for including me. My name is Takashi Kurosaki. I'm a Japanese economist working in Hitotsubashi University in Tokyo, Japan. Probably some of you are not born at that time, but my first visit to LAMS in 1993, when LAMS was a very small emerging university located in Nuremberg. And during that time, I was working on a PhD dissertation on farmers in Pakistan, and I have been working on Pakistan and South Asia, and it is sometimes, and so it's a very, I'm very happy to be back to this LAMS campus and presenting this study. This is a joint study with Uzma Afzal. She's there of LAMS, and Agari Hakram, Abu Shonchoy, and Akib Khan. And title is Organizing Community Health Worker Resources to Scale Child Nutrition Programs in Rural Pakistan. So in this project, we are focusing on growth monitoring through growth monitoring tools as well as the visits by community health workers. This can reduce the child's nutrition program because early detection of faltering growth can enable response from mothers to change their child care practices. So the challenge is that in developing countries throughout the world, child health outcomes are poor, and especially in Pakistan, 44% of children are stunted, and wasting and percentage is also very high, and that ratio is much higher in Sindh than in other parts of Pakistan. So existing approach to cope with these stunting issues, first is the focusing on the lack of knowledge, so that the usually intervention gives the information campaign, or the lack of resource could be the reason. In that case, a common solution is to give cash or asset transfer. However, and also in Pakistan, especially regarding the information interventions, lady health workers under the government scheme are providing the information services. However, the result is not very promising. And all over the world as well, there is a mixed evidence on the effectiveness of community health workers. So the motivation of research is that we test how the community health workers' resource can be optimized to scale promising child nutrition programs in Pakistan. So what is the promising child nutrition programs in Pakistan? This is what we already conducted in slum areas of Karachi. And basically, we tested in-home growth monitoring by caregivers using growth monitoring tools, which is installed in the mother's place, and with active assistance and counseling by community health workers who visited the places every month. And in case of Karachi, we found a quite promising result that after intervention, then height for age Z-score improved by 0.42 standard deviations. And it was a time of COVID-19, so it was a quite difficult time. However, we were successful in achieving that. And if you are interested in this, please see our published paper, January this year in American Journal of Public Health. So given this kind of success in Karachi, in this study, we designed as a more extensive design to examine if comparable outcomes in a rural environment can be achieved. So with this motivation, we basically designed extend or revise the regular growth monitoring. In the regular growth monitoring, community health worker visits the house and contact with the mothers and install the growth chart, and the growth chart is visible for mothers and potentially by fathers and other family members. And then with the help of the community health workers and mother and community health worker together measure the height and weight of the child and record it within their house. So this is basically our intervention in Karachi. So in rural Sindh, what we did is that we continued to try this in treatment 1, home-based growth monitoring heavy-handed. But in addition, we are trying another treatment, home-based growth monitoring light, and of course control to see the overall impact. So in the heavy touch home-based growth monitoring, growth chart is installed, and community health workers gives nutritional counseling to mothers, and community health workers visit the household every month for 1 year. And then every month, mother and the community health worker together measure the height and weight of the child. Now, in the light touch treatment, well, this one worked well in Karachi because the low-income areas of Karachi where we conducted RCT is low, densely populated areas, so that the community health workers can visit the mother monthly quite easily with low cost. But it's not the case in rural Sindh. So in light touch treatment, we replaced the monthly visits by community health workers by the message through IVR calls. And through IVR calls, we encourage the mothers to visit the health facility nearby and measure the height and weight of the children. And also, we gave helpline numbers so that if the mother has some problem with their child or nutrition question, they can contact these helpline numbers for help. And in light touch treatments, the community health workers visited the household for the first 2 months, and then they didn't contact them up to the end line stage. So this, and more about IVR calls. Sorry. In the IVR calls, this is designed for bi-monthly, and the topic related to child nutrition is provided through calls. And short text message also provided. And in the monthly messages, call was to emphasize the need to check the measurements of the child. And contents of this IVR message are perfectly synchronized with the message and counseling given by the community health workers in the heavy touch treatment every month. So through this research, we want to test whether, first question is that similar intervention worked in rural Sindh. Does it have a similar impact as in Karachi? And second question is that the light touch home-based growth monitoring, does it also have positive impact? And third is that whether the light touch is as efficient as the heavy touch one. Of course, it is not expected, but if it is less effective, how less is effective? Third question. And the fourth effective is that these effects, how heterogeneous depending on the characteristics of the community and the mother. And the characteristics of the mother, we are focusing on the education and wealth level. And for the community level, we are focusing on the distance and the quality of health facility, health centers in rural areas. So primary outcome variables is the stunting and height for age. And for secondary outcome variables, we plan to use wasting and underweight and acute malnutrition, dietary diversity, and attitudes and beliefs of caretakers. Regarding the last one, we know that Pakistan has some kind of some preference, social norm and other things, whether they affect the effects. So actually, we are still in the implementation stage, so we don't have the final results in today's presentation. So please looking forward to the results after 1 year, not 1 year, 1.5 years. So we chose the study area using the using information on developments and and chose the Tando Muhammad Khan, which showed the development indicators similar to the average of Sindh, and also did not suffer from the floods last year. And for the village selection, we excluded villages that are too far away from health facilities and too small or too poor or too extremely rich. And then we randomly sampled the households, targeting at the households with children aged between 6 and 18 months at the baseline survey. And we conducted the baseline survey in January, February this year. Intervention started in June this year, and the end-line survey is planned 6 months after completion of the intervention. So the initial design is 60 villages for treatment 1, same for treatment 2, including 900 children each, and the control 80 villages with 1,200 children. And with this setting, we calculated that the power is sufficient for a reasonable effect, which is expected. So for the for the actual intervention tools we use, first is the growth chart. In growth chart, we design with the height of the child at the real size, and boys and girls separately. And this is the helpline number for the light touch intervention, and this is the nutrition advice. And this is used in this way for small kids who cannot stand. And another material we developed is health record booklet promoting child development in Pakistan. And in this, we give the information on nutrition and health and immunization, these kind of things. And then here, I skipped this. Actual recruitment, we finally had a starting sample of 60 treatment villages, similar size for treatment 2, and 79 villages for control. So the baseline characteristics of this sample, the number of stunted children is alarmingly high at 54% on average. And sample includes 23% of Hindu population, which is not different from the average in the Tando Muhammad Khan district in Sindh. And mothers' level of education is low, average with 2.7 years, and all mothers had access to mobile phones, but the percentage with smartphone was 27%. So this is the balance test, and this is too small to see, but anyway, mostly there is no statistically significant difference, so we judged that the randomization was successfully conducted. And this is the baseline diagnostics showing the stunting prevalence by age group, on average 54, but the highest in the 12 to 16 months. This is the most critical period because the children are becoming more, started to eat something other than the breastfeeding. And the stunting rate is slightly higher for boys than for girls, but still girls very high, and the earlier stages, girls stunting is more severe. So I skipped the wasting and the underweight data. So we are facing some fieldwork challenges like weak network signals in the villages, resulting in low response rates for the IVR codes, much weaker than we initially thought, and literacy challenges, especially for mothers and community resource persons who correspond to community health workers. We have some problems in monitoring and coordination, but still we conduct the midline survey and for the subset. So after 1.5 years, we will show evaluation results of the ITT effect using the randomized assignment at the treatment, but in addition, we are planning to do compliance adjusted ATEs so that differentiating the full compliance and partial compliance, because especially for the IVR code, some very interesting variation regarding the level of compliance. And of course, we will correct for the attrition. So this is the basic stage of this project. Thank you very much.
So thank you, Takashi, and thank you for actually keeping the time. So that is excellent.
Oh, thanks.
And I am also the discussant of this, and also in the interest of giving you some space, I will focus on the most important ones and actually discuss the rest with you afterwards. So I think it's a great thing that you keep on the topic and kind of from the past learning, you take it one step further. I think this is really great. Also thinking about the intricacies of the rural areas and design a light touch intervention in light of travel distances. So I think this is very nice. Now, I wonder, why didn't you, I also looked at the old paper, and actually, it turned out that the growth chart has been shown to be ineffective there, right? So why didn't you take just the most effective treatment, which is just the visits without the growth chart, as kind of your base treatment, and then do this, light touch on top, or basically as an alternative? So why did you, again, include something where you found that it was not effective? So basically, maybe it's signals that you don't trust the results so much. Then, your paper is kind of, shows your design at this point, so I can't see everything, but what I missed a little bit is kind of the information on what nutritional information you exactly give, because that is very important for theory of change, right? So what are the channels through which you affect behavior? The knowledge of the SOPs, the adherence to SOPs. I guess when you talk about partial compliers, you will somehow measure it, but this was not apparent. What are the expenditures for relevant food items, and so on. In general, your draft was relatively silent about, the theory of change. And I think, in particular now, it's a good time. You present before the results, so take the time and think about it, and then specify or think about what you need to measure in the end line to be able to really track these channels. So in general, I think, where does the change come from of behavior? Are these anomalies? Are this just lack of information? Behavioral anomalies versus lack of information. So a bit more like a framework thinking might be some opportunity to improve the paper. So as far as I've seen it, but you can enlighten me. So that's it. And you can choose to respond or take further questions from the audience.
For Andreas' comment, yes, you are right. Actually, I didn't explain because of the time limit, but in our pilot survey in Karachi, we tried 3 versions of growth monitoring tools. Actually, community health workers without growth monitoring tool was also tried, and that intervention was as effective as the community health workers monthly visit with growth monitoring tools. So in that sense, yeah, logically
it was
speaking,
less effective in the paper.
Well, yeah, but the effect difference is not statistically significant. But yeah, right. Yes, in that sense, it is more natural to continue the intervention without growth chart. However, in rural setting, when we design the light touch treatment, then something needs to be at the mother's place so that the mothers can remind of this type of importance of child care and nutrition, not only from IVR caused by monthly, but something physical. And booklet is one of them. So booklet and growth chart with the real size. We thought this is inevitable for light touch treatment. So for that reason, we keep the growth chart in both heavy touch and light touch treatment in rural intervention analysis. Details of nutritional information is in that appendix in the Karachi paper, but I forgot to add it, so I'm terribly sorry for this. And regarding the lack of theory of change, yeah, we discussed something in Karachi paper, but yeah, we will improve it. Thank you very much. Yeah, so please collect some comments from
my name is Atif Arif, and I work in a bank as a learning and development head. And my couple of questions. Number one is regarding awareness of this very important thing. From all the panel presenters here, one thing that is very common is regarding the awareness of like immunizations. Even as a father, I don't know, I have been going for my kids' vaccination, and the doctor is advising me to do this and this every time, but I am not actually aware that what are the number of vaccinations. And Dr. Javed also said that the timing is very important. So one thing is this, is awareness. Second is, Takashi, what are the contents of IVR that you are using? Right now, if anybody in Pakistan calls anybody on some other's mobile, you will receive a mobile message on Hajj. So there is a massive campaign on Hajj awareness right now across Pakistan. So can we have such programs through some government creating awareness on mental health as well as nutrition as well? And lastly, maybe if you can also shed some light on the role of community health workers. It has been a subject of great debate over the years. They are there in the primary health, secondary health, and tertiary health care across various regions and districts of Pakistan.
So there was another hand.
Hi, I just had a quick question. You mentioned as your secondary variable that you're looking at the attitude of caregivers. So I was just interested to know how that's being measured in the study, and is there a corresponding baseline measure of that included as well? Thank you.
Yeah, thank you very much for important questions. Yes, for the awareness, our hypothesis is that mothers and, of course, fathers to a higher extent, they don't understand the importance of timely immunization, vaccination, and also nutritional elements. And traditionally, the lady health workers package include this, but it was not delivered to mothers effectively. Actually, one of the theory of change, which Andrea also mentioned, is that by utilizing community health workers who are employed from the community and more motivated through the NGO's incentive structure and other things, they are more effective than government recruited lady health workers. That is the one of the theories of change we had in mind. And that is the role of community health workers, you asked. Regarding the attitudes of women, starting from the Karachi study, we include the question that, breastfeeding is important or not, and equally important for girls and for boys, and education is important for boys, and for girls as important as for boys. This kind of bunch of questions, like 20 or more questions we adopted in a pilot survey in Karachi, and we collected information both from in baseline as well as in end line, and not only from the mother, but also if the the mother-in-law is existing, co-resides with the mother in the household, and if she gives some help to the mother in child caring, we ask the same question to these one generation ago persons as well, so that we are able to analyze the difference or similarity in intergenerational beliefs of the role of gender and other things. And we are doing exactly the same things in this Tando Muhammad Khan intervention.
Okay, we would have time for maybe one more question. But then I would say we stop on time, actually, which is really surprising and great. So yeah, I think you can put up my presentation. So I'm last. Okay, so welcome everyone. And I was really happy when I read the call for the conference, because like the topic of the conference is really spot on to this paper. It's about equity or inequities. It's about social justice, social protection. So it really hits the topic, I think. So I'm looking forward to your feedback. This is about how education is a determinant of being able to utilize social health protection. So, and the motivation here is really that social protection programs in general, they are designed in a way for the poor to benefit, right? So this is something you assume that they protect automatically the disadvantaged group. And we've seen social protection programs like cash transfer programs, social pension programs being implemented increasingly at a global scale. Also social health protection, so social health insurance programs have taken center stage. We've seen in the last 1 or 2 decades massive reforms in that respect, with up to 2 billion people on a global scale being enrolled in such programs. So it's massive, and you assume that you protect the right people. Now, one problem of this is, of course, targeting. I mean, there's a broader literature on this, that kind of targeting is difficult if you don't observe income. Yeah? So you have to use proxies. We know all this. But I think there's a bit less evidence on once you are eligible, then whether can you use it. And there is some evidence from other contexts that actually it's not necessarily those within the scheme that are disadvantaged who have the same chance to use it. So for example, from the US, we know that the youth, like the enrollment in publicly funded charter schools, which are designed to benefit the disadvantaged. It's not necessarily the disadvantaged that enroll in this. We know from Denmark that the utilization of social health protection, social protection programs actually has like an education or a socioeconomic status gradient. Like they seem to kind of, the higher educated, higher SES people use it more. And in Germany, the spots for subsidized childcare are primarily taken from higher educated parents. So all this, is kind of evidence that, it might not be so easy to get to the benefits. It might be not enough to, to just install programs. We have to think of like the barriers to using it. Yeah, I think this is very important. We have little evidence on this from lower middle income countries. We have certainly no evidence on this in social health protection. And this has to do, of course, with the fact that to analyze this, you need utilization data, administrative data from these programs, and it's not always easy to get. And maybe it's also an aspect that hasn't been, considered so much. So also, there's little evidence on the causal role of education, like whether it's education that helps you navigate these systems. And this is really where the contribution of our paper is, where we try to contribute to the understanding a little bit. And I hope in the context of something really relevant here. Okay, so if we think about utilization of social health protection programs, we can also look at what do we know about health insurance in general. So actually there is no study, to our knowledge, that studies, once you are enrolled in health insurance, who uses it, really. But, there is studies on the relationship between education and demand for health insurance and enrollment. And there's also, studies that education helps you to understand these policies. Okay. At the same time, there are good reasons to believe that education might affect how you are able to use policies and schemes in general. That the one is, of course, that education improves your reasoning and decision making. There's literature on that. Also, there are education causes tons of things to change, and amongst these things, it's also health behavior, right? More educated people tend to, have better health, invest more in preventive behavior, and so it changes also health needs. All this we need to take into account when we think about this question: how does education relate to the usage of a social health insurance program or social health protection program? So there are all these different channels, like education affecting cognitive, non-cognitive skills, also income, of course, the economic returns to education, and then, as I just said, the health needs. So I think I would separate this a little bit between the health needs and the other channels, because health needs, as I said, you might have lower health needs if you're more educated, and that maybe leads to a lower utilization or lower need of utilization. But then all the other channels are kind of related to barriers. Yeah. So why? Cognitive, non-cognitive skills might affect your medical uncertainty, improve cause-effect thinking, improve memory, improve insurance literacy, all things that are related in a positive way to navigate the system and or claim services. Income also, might make transportation costs more affordable, reduce your financial uncertainty, and again, helps you to overcome these barriers. So all these are kind of barriers in the system that are not necessarily desirable, okay? The fact that you have a different health need is maybe not linked to this kind of specific barrier, it's just, your personal circumstances. So this might be something, if we are thinking about barriers, that we want to control away. All the rest is kind of interesting, and overall, it's also, by the way, just the descriptive link between education and the utilization is a distributional question, like who takes most out of the system, yeah? Okay, clarification question, but yeah, quick.
Do you want to see the impact of education on the take-up of health insurance program?
No, not take-up, it's about wait, just bear with me, okay, please, then, yeah. We're looking at this in the context of the SEHAT Soldat program, or nowadays also called SEHAT Card Plus, which is an important reform rolled out since 2015-16 in Pakistan, initially in Khyber Pakhtunkhwa and Gilgit in selected districts, but then also around the same time the federal program started in selected districts, and it covers inpatient, that is hospitalization care, in both private and public facilities. And it was really starting initially in a few districts. I will have to, I want to show something more. So here you see in Khyber Pakhtunkhwa really how it started out. At the beginning, selected districts, and it rapidly expanded. Like in 2018, you went from limited coverage to enrollment of up to more than 50% of the population, right? So really a large program. And then this is the global, the national scale. Like you see here, Khyber Pakhtunkhwa being like really massive in this, and then selected other districts around the country. So this is kind of how this was rolled out. And so I've been, in a position where I studied this since the inception, right, or even before it started. And what in our research, we've seen all along is that, first of all, utilization of this program was below expectations. Also, awareness of the program is an important concern and certainly a barrier. And we've seen that also awareness is very much related to whether people have some basic education. Yeah? So, overall, system is not necessarily easy. There are selected facilities, there are selected health cases that are covered, so it's not very clear. Awareness about what are the prerequisites to use it are important. This might be a particular problem for the disadvantaged households, and so the question is like, do you need to be educated, right, to use it? We studied this in the context of data that we have from before the program start. Actually, we have also afterwards, that's on another project, but we have individual level data on the more than 40,000 households members from 6,000 households. We have data on education, self-reported health status, and many, many other variables. And the nice thing is we can combine it with admin data. And like this, we can see that around 4,000 of these households enrolled in the program officially, and we see roughly 13% of them claiming over the period of time that we observe. And with that, I go to the admin data that we have, and I think this is a bit exceptional. We have the universe of all enrollments between 16 and 18. This is where the major enrollment drives happened. Yeah? And this is more than 1 million households here. We also have the utilization data now running until 2020, and this is 200,000 claims that have been observed in that period, and with some details on this. We can also combine this with the census data that we have and used for sampling the 6,000 households that you've seen before. So there we have census data on this, and they already include some interesting information, actually, that we'll exploit later. And we collected school census data, like the census of 15,000 public primary schools being built since 1800 in the province. And we use that to construct an instrument for education. So, okay, we start out simply with basically correlating whether a household claimed with an indicator of household education, which is basically whether someone in the household older than 16 has some primary education. So we're talking about a target group where 38% have primary education of these older than 16, and a third of the households have nobody with primary education in there. Yeah? So that we take as like an education indicator. We control for a bunch of household characteristics, and importantly, location effects and enrollment time fixed effects. So you've seen these enrollment patterns, like this expansion, and that has not been uniform. So that means that we really have to control for this, because the longer you're enrolled, of course, the higher your chances are to claim. So this is an important control here, and also the location-specific effects. And what we see, if we run this quite simple conditional correlation, if you want to say so, then we see that indeed education, the education indicator relates significantly to whether households are able to claim. The baseline chance are 13%, and this improves by like 2.5 percentage points or 20%. So we see that education seems to be related. I told you before that I would like to separate the channels a little bit by, the one through health, that is determines your health needs. And our attempt to do this and to control this away is to look at kind of which households at baseline had some unmet health need, And we condition on those households that reported some unmet health need. And conditional on that, we see that the effect of education actually comes out more strongly. Okay, this is exactly what we would expect from the theoretical framework, because, if the more educated households have lower health need, it kind of biases the estimate downwards. If you control it away, then the effect becomes stronger. So in terms of the framework, it fits. Okay, but you might wonder about precision here. Of course, it's a limited number of observations, and you see this reflected by the limited number of stars that we're all looking for. So what we see is that kind of the control variables that turn out to be important are all variables that we have in the census data. So why not run the whole model on the census data with like 20 times more observations? And that's what we did, basically, and that's what you see here. we have household composition, household size in the census data. That turns out to be the most important factor, and also the locations, of course, enrollment quarters, and so on. We have that, and what we see as an effect, if we do this with 100,000 observations, we see very similar point estimates, 2.3 percentage points instead of 2.5. This is exactly what you would expect if you do this whole thing on a larger sample, and with precision being increased by a factor of 3 to 4. So I think there is no doubt now that this is a statistical, artifact by chance. This, this conditional correlation is there. Okay, but you might still be worried about, is this just spurious correlation, even, putting in these controls? And so we're also interested in the causal effect of education to overcome these barriers that we see in this program. So what we try is to use the public school construction as an instrument, basically with the idea that those who are first exposed to a school that's built, and with a lot of schools built, that they should have like a kickstart in education, should improve their education, chances to receive education, and then second stage, then the chances to claim. This is also possible with the census data. Unfortunately, due to time constraints, I don't have time to go into details, but what we see is that the instrument is indeed strong enough in the first stage, and by the way, we can only do it for female education because male schools have been built quite earlier. So we don't see any untreated people in the sample. It's actually only women where schools are built late enough, in a way, unfortunately, that you see still generations that are untreated in a way. And so we can run this only for female education, and we see the effect of female education being confirmed and coming out even more strongly. By the way, I think this is something I jumped over a little bit. We did this in the census data results, without IV. We did this, of course, we re-estimated this point estimate, but we also have enough sample size to differentiate between female and male education, which both kind of turn out to be important and influence the chances to claim under the policy. Okay, so that brings me basically to the wrap-up of the whole thing. So we've seen that in terms of absolute numbers, there's kind of massive implementation of this social health protection scheme. But, and this relates a little bit to the political economy discussion that we had at the beginning, right? You think, okay, I implement this program, massively number of people targeted, and all is good. It's not true. There is, you have to think about the process. And this goes beyond the case of Pakistan and beyond this case of the social health protection program. I think in general we have to be mindful of the complexities of navigating a protection scheme, and who are the ones that can claim from it. We cannot leave the disadvantaged people alone with this, with these complexities. But think about it. So we need a better understanding of these complexities. Maybe we need to reduce the gaps in coverage, which also create the complexity, and provide guidance, in particular for the disadvantaged households that have problems to understand, where are we going. By the way, we have really an intensive, since a couple of years, research project on measuring the complexities in healthcare decision making, and then on how actually certain, financial but also medical advice can help you to overcome these complexities. So this is but this is, I think, a very good motivation for, what we do there, and something to really keep in mind. So thanks, and yeah.
Thank you so much. I think very interesting study, which is particularly looking at Sehat Sahulat card, which is very prominent in terms of the coverage and also the scale up by the KP government and then nationwide as well. I will not go into the summarizing the paper for the interest of time. However, I have few questions about initially the take up. so one thing that I'm very much concerned about is the take-up is very low. And do you have understanding how that how that is varying over time even? Has that substantially improved? Is it different from the nationwide numbers, the take-up that you're looking at? So some understanding on the lines that yes, it is low, but has it changed over time because of awareness or other factors? And then is the take-up generally low all across the nation, or is it just low in KP, which means then moving towards what could contribute towards higher take-up? Then also, I'm trying to think about what type of claims have been made. I think you have data on the type of claims. So essentially, I'm relating this to maybe you're saying female education, but which are the type of claims that were essentially there? Maybe it's antenatal care or females who are generally using it primarily because of reasons, not just, oh, they are severely ill, but they are the ones who are primarily more have urgent needs to take up these claims as well. So do you have some idea about what were the type of claims as well? And then finding across those, then in trying to relate it to your female education variable as well, which is your IV. Then one thing I don't understand is a household survey that you're running, what is the coverage of that? Is that across all the areas, or is it stratified across, or coverage is from particular areas? Because then I think take-up is coming from that part as well. So I think 5, 1, 12 were the ones out of the entire one. So what is the coverage of the household survey? What is the distribution across the entire area? One thing I'm also concerned about is you're saying that, so I think 2 essential factors. We're saying that it's female education which is more important in terms of claims. Is it, so I have some few thoughts about that. Is it female education that is more important here, which is taken as IV, primarily because those are the ones who are claiming more, and that's why you're looking at getting the correlation? It's primary schools, are they the ones who are decision makers in this particular aspect as well? Who is the decision maker of the household as well? I think that's something I'm not able to understand. Is it the education which is making a difference, or is it those females who are also the decision makers as well in those households as well? So I think understanding those channels would be provide much more idea. I think another thing I have is you're looking at primary schools, which is prehistoric. Another thing I'm not sure about is what is the distribution of these health facilities as well. Historically, if the health facilities are correlated to the distribution of schools historically, then the two are correlated, right? People will get more claims or can make more claims if there's health facility available. And I think the distribution of that historically is similar to the distribution of schools as well. Because I think areas, the distribution of schools and health facilities are based upon area and coverage. And I think historically both should be correlated. Areas which have maybe schools earlier could also have health facilities earlier as well. And people can claim primarily because there are health facilities. In areas where there are no schools, people might not be able to claim in those areas as well. I have some initial thoughts about this. And then, yeah, I think that's pretty much. Thanks.
Okay, thanks so much. Maybe I quickly, not through all of them, but maybe some of them I answer and then we open up. So related to the last one, a good point. We are definitely checking also validity aspects. So, I mean, we're having the location fixed effects in there. So, I mean, you would need to have something more than just a simple correlation story that, you know, like the school building. Because basically what we're looking at is not just, you know, whether in some district, some union council it's more schools built, but actually which generation is exactly affected, you know, and that will make a difference. So yeah, but we're looking into this, and we're trying to finding correlates and to basically to see whether there is some of this correlation going on. Decision maker, there is something in the paper, like it's basically often more males, of course, the decision makers, and it depends a great deal on education. That's what we show, like it depends on age, and education. And the age gradient has informed us also on like, how to define the household education indicator, because we expect that older than 16, this might start to matter, right? So this has informed our indicator of education. We are not saying that female education is more important than male. It's actually, both are important, but it's just that the instrument can only work on the female education, so we can only back this channel up. That's unfortunately the case. Utilization is in both federal and the provincial program. It's a problem, but picking up, I mean, a little bit. Now we're getting back to political economy. At the end, it depends on how much money is in the pot, right? This the carrier of the risk is not really carrying any risk, actually. They are just having a pool of money, and they're making sure that there's not spent much, not more than what they have. So this is creating, of course, some bottlenecks. And what we're seeing right now is that funds are being reduced for this because of the current situation. And of course, then also utilization is reduced because of that. This kind of trickles down. But it's not going away. That's a good thing. And that's maybe also a political economy aspect. It has been a massive reform. You can't just take it away. And that may be a good thing. And that's also what makes me very motivated to research on it. I leave it at that, and maybe there's some time for further questions. So I think we have two. Sorry. Both of you.
I think you briefly touched upon that, and the question is about supply side. So is there a systematic difference between, for instance, public institutions accepting the Sehat card compared to private? My understanding is that maybe some of the private institutions are accepting it more than public institutions. And mostly about if you go and if you're not able to use the card, then you're finding a null effect, but that's just a supply side issue, right? Also because of the change of the government and the interim government, and so the future of this program.
Mm-hmm.
Andreas, it's really interesting that you are researching on this topic. My family runs a hospital in Peshawar, and 90% of our patient load comes from the Sehat card system. So we deal with primarily the poorest of the poorest people. So some of the observations that I saw are very interesting. One of the questions that came about was about the supply side. So the private sector has come in massively and built these facilities to give access to these people in the areas where there was no access. I mean, like imagining cardiac healthcare in Swat or in Sawabi or in Mansehra, which are far-flung area where the tertiary care setups don't exist. So that's been a very interesting aspect of the supply side. One other thing that you mentioned, that this program might not go away. I mean, like, you would be surprised at what can happen in Pakistan, but since we depend on it as well, and so we hope that it continues in the future as well. One last thing that we felt while we were doing providing these health services, is that we did some multiple camps for poor people in the region that we are located. So our area is just outside Peshawar, in the outskirts of Peshawar. And it's a rural area. So when we went around and we did these medical camps, we discovered that there were hundreds of people who had unmet needs because they just did not have any idea. From one village, we got 20 odd people who were above the age of 60 who were basically blind, and they just needed a surgery to fix that. And the surgery would cost probably $50 to fix that, but they did not have that access. So, I mean, like, it's been a very interesting path for us so far, and I'm really happy to see that you are working on these topics, and maybe in the future we can get together and talk about some of the aspects of it. Thank you.
Thanks. I think there was one more question. Maybe we collect and these two, and then I respond.
Just a few thoughts, maybe. The one is this, that look, this program was started in KP, and then it trickled down to the other governments, motivated by their political motivations initially, and now it has become a necessity. Now, when they started this program, they used to run the campaign in TV or newspapers all over, right? So which means the one thing is that they actually tried to engage with the people, motivated them to enroll in the program. So that you, I think, need to think a little bit broadly, right? So which is that your left-hand side variable is perhaps usually affecting not the...
Conditioning on enrollment. We are only talking about enrolled people.
Yeah, but, okay. No, the thing is, yeah, they're not taking claims. Maybe the education, I don't know if it's education per se or information. I mean, maybe highly educated people, they are perhaps wealthier people, and they would not really care about few hundreds of rupees of claims, maybe, right? So maybe there is some linearity, non-linearity in your education level, so maybe you want to test for that. And maybe income is perhaps the most driving factor. I mean, otherwise rich people go to private hospitals here. They don't really go to government hospitals as such. So maybe you want to control for income too, and think about some non-linearities in there as well. Yeah, thank you.
Thank you.
Hi. There's one thing whenever I see that such policies has been making, and for a very sustainable project, I believe there needs to be some kind of accountability. Whenever you people are spending on such projects and making such researches and the pilot projects, then the people who are hiring the providers of those facilities for these projects, they need to be accountable license holders, I guess. So the accountability whenever the stakeholder money is being spent on these projects, the way IMF or World Bank, they only provide it because they want a proper outcome for it. And if there is no accountability without a license holders, without procurement specialists, I think no such projects will be sustainable and be running for a long term, and it will not show any impact. So this is one of the comments I wanted to make. Thank you.
Okay, so maybe very quickly on these points. So on the accountability, I think research is one way to establish accountability. So basically to see what are the impacts, and that's what we're trying to do. And to some extent, some of these questions are still open in a way. This point on education and income, yeah. I mean, I was saying that this education effect can go through multiple channels, and but to some extent, we can control for the income through these poverty score levels, indirectly even already by controlling for these enrollment times, because it was basically the timing depended on the poverty scores. We are, this is already a bit in the fixed effects, but we can try to control for the proxies of income or wealth that we are having. That's maybe a good idea. I think we should talk on your experiences from the supply side, and there's this very important point also on the difference between public and private institutions. And yes, I've heard tons of these stories how it makes a difference, and actually that for public institutions it makes even more of a difference, right? Like who is coming? And kind of that you need to kind of even have more, to be more persistent to get in there. We can test that in a way because we have the providers, and we can maybe see whether it makes a difference more, education makes a difference more for public providers or private providers. It's a very good idea. Yeah, so I think with this I have to leave you guys to the lunch break also. We have taken a bit more time. We've started a bit later. But yeah, thanks a lot for all these comments and your engagement.
you.